Good evening, everyone. Once again, welcome to today's webinar. Hope you're all doing well. Taking this opportunity to appreciate the Kenya Society of Anesthesiologists webinar organizing team, all participants that have joined, both local and non-local, the sponsoring company for today's webinar, on a very interesting topic of ovarian hyperstimulation syndrome. If you have any questions concerning the presentation, please feel free to address it in our chat room. They will be answered at the end of the presentation as we go by. So we want to start by introducing our speaker today. Today we have the honor of Dr. Wanjiru Ndegwa. Hope I'm pronouncing your name correctly, Daktari.
Yes.
She's an obstetric gynecologist with a subspecialty reproductive endocrinology and fertility. She's also a director of Footsteps to Fertility Center treasurer and also an assistant secretary of Cysts, Kenya Society of Endoscopic Specialties, a board member of Confederation of Fertility Society. Karibu na daktari, educate us on today's
Thank you very much. To all the anesthesiologists, I am honored to be to even have been asked to present today. It is a topic that is very close to our hearts as fertility specialists. This is what we all really hope we never get. So as I speak, we do know that it really does take a team to manage OHSS. It's one of the syndromes that do happen to patients who we deal with, especially in the IVF realm, or patients who are struggling to conceive. So without further delay, let me start my presentation, and I hope you will all gain some insight on how to manage these patients. They're not very many who come across us, but it's important for us to understand what it means and how we can prevent the syndrome and how we can manage it. So today, I will just start. And so what ovarian hyperstimulation is, one, it's very important to know that it's iatrogenic, meaning we are actually the causes, the fertility specialists cause it. It is seriously life-threatening. I've had patients go to ICU with the condition. So it's something that, can easily take a patient who was well, had no problems, wanting fertility, and we end up in ICU and with bills of 2 million. So it's something that we really, really want to prevent and manage well when it does occur. It's obviously associated with ovarian stimulation. And it's important for us to note that it can be from stimulation with gonadotrophins, which are the medications that we use to hyperstimulate the ovaries. And that's to give us more follicles as we retrieve. But also, it can also be caused by oral ovulogens. And clomiphene, I've actually seen a couple of patients who have come with this syndrome purely because of clomiphene citrate. So really, it is it's interesting. It is associated with HCG. So during our IVF process, we use gonadotrophins, but at the end, to trigger maturation of the oocytes, we have to give HCG or give something to trigger the final maturation phase so that the oocytes, we get them at an M2 or a metaphase 2 phase. And usually we use HCG, but HCG is actually what will cascade and cause OHSS in some patients. So it is, it's a very important link. Also, that HCG is what is the hormone that starts increasing in pregnancy. So if our patients get pregnant, then we do or will get ovarian hyperstimulation syndrome in patients who had a risk factor. The most important thing to note, obviously, is that it is preventable. So we have a role as doctors, as gynecologists, as IVF specialists, and even as anesthetists to help prevent the whole syndrome. I'd like you to have a look at the diagram. If any of you have been into an IVF lab or worked with IVF doctors, this is what sometimes we see on the screen of a transvaginal scan when we're doing the oocyte retrieval. And these are just the ovaries which are hyperstimulated. They're together, multiple cysts filled with the follicular fluid. Sometimes we have a lot of ascites around them, and this is the picture that scares a lot of us, especially when we were younger and starting to practice. This was very scary, but now we have learned how to manage it. So what is the incidence of OHSS? Is it very common? I will say that it's more common for younger doctors. So when I was starting out, I had lots of cases of OHSS, and I had patients who we'd actually have to take to ICU, as I've said. But right now, I rarely admit a patient for OHSS. We are able to manage them on in the clinic mostly. And what are the risk factors? The risk factors for OHSS are, one, most important is young age. So we do know that there are a lot of donor cycles happening in our clinics. So the younger women who are donors are more at risk for OHSS. Patients who have lower body mass index are also at risk. Patients who have polycystic ovarian syndrome, and these are patients who have lots of follicles, who have higher anti-Mullerian hormone levels, are more likely to have OHSS. And then patients who have a previous history of ovarian hyperstimulation syndrome are also more likely to get a recurrent OHSS in another IVF cycle. So it's an important history to take of patients who have had IVF before, so that we can try and prevent it. So what's the pathophysiology of OHSS? We do know that for any patient undergoing IVF, what we are trying to do is get as many follicles as possible, because right now the new craze is let's get as many follicles as possible, and then we can freeze, and therefore reduce kind of the cost for the patient. So if we are able to get 20 follicles from a patient, 30 follicles, I know I've even gotten at some point 45 follicles or 48 follicles is the most number I've gotten, but that increases our chance of pregnancy. So we do try to overstimulate the ovaries so that we can retrieve, or during the oocyte retrieval, get as many oocytes as possible. But what does that do to the patient? Obviously, there's an acute inflammatory response when we do ovarian stimulation, which has the inflammatory mediators. And will then cause us to get the acute phase proteins, and those are the especially vascular endothelial growth factor. So this is known to be the main cause of OHSS. It is found in the granulosa cells. It is stimulated by HCG. So obviously, the more granulosa cells we have, meaning the more oocytes we get, the higher the amount of VEGF in our system. And then also HCG will stimulate it. So if we use the trigger, a HCG trigger, we'll get more VEGF. And what VEGF does is that increases vascular permeability, and therefore the fluid shifts from the intervascular space to the extravascular compartment, and there starts the syndrome or the cascade of OHSS. There are other also factors. The renin angiotensin system also is part of that, especially what the intracellular or intraovarian RAS system is also a mediator of that. And this will RAS is actually stimulated by HCG, so that will also cascade and will have the shift of fluid and an increase of vascular permeability. We also think that interleukins, tumor necrosis factor, all this will also play a part in this. So it's a whole cascade of elements that will cause ovarian hyperstimulation syndrome. But the main cause is VEGF and the RAS, ovarian RAS system, and which will cause vascular permeability. So what does this then give us in terms of a clinical picture? So of course, when we have increased capillary permeability. Sorry about the quality of this slide, but I did want to give it because it shows very well what we are dealing with. We will then have fluid, and the fluid is shifting from the intravascular to the extravascular compartment. So if we can just look at the extravascular compartment, what will happen? The patient will present with edema, and that will mean that the patient will gain weight. So in these patients, we actually have them, you see them at some weight, and the next day they're gaining a kilo or 2 or even 3 per day. And then we therefore know we're getting into trouble. We also have an increase in the ovarian volume. The ovaries are usually about 4 centimeters. We've had patients who the ovary increases to 20 even centimeters, and this is in severe cases. We also will have ascites, and therefore the patient will present obviously with a swollen abdomen. It could be tense, it could be not so tense, but it will also be associated with pain. And then we could have a hydrothorax, and even and fluid also in the pericardium. So all this will cause dyspnea and other symptoms. So that's when fluid is going into the extravascular compartment. So in the intravascular compartment, obviously we'll have a hypovolemia. So we have things that are associated with this. The patient will become hypotensive, can come into shock. Patients could also get hemoconcentration and come with factors of thrombosis. They'll also get, there'll be shift because of low albumin, and then we can get reduced renal perfusion and oliguria. So these are especially important to take care of, especially with the donors that we do get. Some of them, I do know there are patients who have collapsed and have actually died because of this syndrome. So it's really important to check and really monitor these patients very well. So what are the clinical manifestations? I'll take them in this way because we do classify OHSS into the mild, into moderate, and in severe. So in mild, in cases with mild OHSS, all we have is some abdominal distension that can occur. We can have bloating, but it's important to note that most patients who are undergoing any ovarian stimulation will have bloating. So it's not a very key sign. We'll have bilateral ovarian enlargement. As I said, the ovaries are 4 centimeters and could grow to even 20. So for a lot of patients, you will feel the ovaries have enlarged and you can feel them even at a fundal height of at the belly button, which is a 20-week pregnancy. We do have weight gain, and we'll have nausea for most of these cases. For moderate, we have still the same thing, abdominal distension, we have weight gain. Now we're starting to have the ascites. We'll have abdominal pain, we'll have nausea, vomiting, and diarrhea. And with this, we can also start having some shortness of breath. With severe OHSS, this is where there is a lot of trouble. Now we start having third spacing, so we have rapid weight gain. These are the patients who will be gaining even 3 kilograms per day. When you assess them, you will have then the tense ascites, you'll have a pleural effusion, you could have a pericardial effusion, you can have tachypnea and dyspnea, hypovolemia, of course, characterized by low blood pressures. You can have a tachycardia. We'll start having symptoms of renal failure, electrolyte imbalances. You'll have coagulopathies. Of course, with the increased risk of having pulmonary embolism, DVTs, and all these other venous thrombotic events. So it's really, really important to understand where the patient is. Is it a mild case? Is it moderate? Is it severe? Because that dictates how we will manage the patient. So I would like to then just talk about the clinical manifestations in terms of what we see and what we should assess in the lab to just make sure for the severe patients. So severe is not too common. It's maybe about 2%. And the critical cases are maybe 0.5%. So in severe OHSS, we will have large ovaries, as we said, 12 centimeters and beyond, even 20 centimeters. We'll have ascites with or without a hydrothorax. We'll have hyperkalemia. So we usually have high potassiums. We could have hyponatremia, hypoproteinemia, oliguria, and usually it's less than 300 mLs per day. we could have, and patients could also come in hypovolemic shock. In a hemogram, we'll find a hemoconcentration. Usually it's more than 45% of hematocrit in patients who have severe, and their WBCs are elevated to about 15,000. We'll also have liver dysfunction and increased blood viscosity and all the other thrombotic events. But it's important to monitor this because it does tell us when we need to admit the patient, and are we admitting the patient in a normal ward, or are we admitting the patient in ICU or HDU? Now, for critical OHSS, we have very severe ascites, we have hydrothorax, we have all the effusions, but important is we have hematocrit of more than 55%. We have WBCs of more than 25,000. We have severe oliguria. We have creatine clearance of less than 50 mLs per minute. We have acute respiratory distress syndrome. So these patients come in and are really, really very sick. And you can actually see a patient. Sometimes I joke with the donors that we see that I just actually have to look at them. When they're coming back for review, you look at her and you can see somebody who is severely compromised, but it is important to do the test, obviously. So what is the management of OHSS? The prevention management, but this I'm talking for you, especially as an anesthetist. You're not so much in the preventive phase, but I will talk about that later on. We are more into the management when the patient really is in hospital and needs critical care. So I'll just briefly describe for the outpatient management. Usually these patients are the ones who have mild to moderate cases. And it's important to note that most outpatient management is really a wait and see. When they do come to the clinic, we will obviously advise for hydration. I want to say that hydration is the most important factor for OHSS. In fact, I tell anybody who has the risk factor, or we think will go there, if you hydrate, if you drink your 2 to 3 liters of water to replace fluid in the intravascular space, they will not go to the severe. But if the patient doesn't, then those are the patients who end up in theater. So it's very important, first and foremost, to have all patients understand that hydration is key. They need to drink the water. Some patients, it's very difficult. So we also need to be aware that they have the nausea and vomiting. So if you're nauseated and bloated, then it might not be very easy to drink the water. And therefore, for those patients, we'll ask them to come into the clinic, and we either every day or every other day, depending on their condition, we just give them 2 to 3 liters of intravenous fluid as they wait on the bed, and then they go home in the evening. But it's a case-by-case assessment. But I will say that usually it will regress. It's a self-limiting, it regresses actually once the patient has her menses, the syndrome disappears. So it will really regress in 10 to 14 days. Now, when the patient comes into the clinic, what do we do? Usually I see them every other day if it's a moderate. If it's mild, I'll probably see every 3 days or every 4 days. And usually until she's out of danger, we do a physical exam, which is very important. We need to check, does the patient have ascites? Is she compromised in any way in terms of her respiratory function, and edema? What is the edema? So we do a physical exam. We take the abdominal girth and see how is the abdomen growing. If it's growing too fast, then we know we're in trouble and maybe need to admit. We also do a pelvic ultrasound or transvaginal ultrasound just to monitor the amount of ascites and decide, okay, what are we going to do with this patient? We also then monitor the LFTs, we do a full hammogram, and we do a coagulation profile. This is not for every patient, but those who look like they're going into severe, that's what we'll do. More or less, we do a physical exam and make sure that they're okay, are they drinking, and just make sure that the patient is okay. But now, when do we need to admit? Of course, if the patient develops dyspnea or has a decrease in urine volume, or starts having symptoms of any thrombosis, I mean, we really have to admit. So on admission, what are other indications for a patient who we need to admit? Any patient who has severe ascites and severe abdominal pain should be admitted for reasons that severe ascites, maybe we need to drain and for abdominal pain, there are many other differentials that we will discuss later, and therefore that is why we need to admit. If they're having severe nausea and vomiting, they're not able to retain the fluids, we're not able to, we're giving them fluid in the clinic, but they're not still retaining and it's just becoming a mess, then we'll admit. If there's profound oliguria or anuria, we'll admit. Hypotension, patients who are having respiratory compromise with tachypnea or dyspnea, lightheadedness, syncope. Now, those we just have to admit. If when you're doing your observations of UECs and LFTs, we have any abnormalities, we also have to admit such patients. So what do we do to a patient when we have admitted, which is quite important because this is where the team comes in. I know for me, when I do admit a patient who has OHSS, I would admit I'd have an anesthetist on board, and I also have a cardiologist most of the time on board, and myself, so that we are a team and we are all gauging the different parameters. So it's important for us to monitor and assess, and by monitoring, we need to monitor every 2 to 8 hours, every clinical parameter, her respiratory rate, obviously, her blood pressure, and pulse rates, because they can have a tachycardia as well, and temperatures, obviously, because she could have fevers from other things. We also need to do a complete physical exam daily, obviously avoiding bimanual pelvic exams, but proper abdominal examination with abdominal girth recordings. We also monitor the weight daily. We'll do ultrasounds on and off, not too often, but for patients, depends on how compromised they are and what we think about their ascites, especially if we are tapping, then we'd need to do more ultrasound, sometimes daily, sometimes every other day, sometimes every 3 days. And then obviously the daily monitoring of fluid intake and output. So for patients who are able to drink, they usually just tell us, record their input, and also when they go to the toilet, then we ask them to void and calculate, or void in a bowl and record what they're voiding every day. For patients who are severely compromised, then we have to put in a catheter and actually estimate what is going in and out every day, and put them on fluids. So we also have to do a pulse oximeter on these patients. It's important to do if they're starting to get respiratory symptoms that we are questioning whether there's a pleural or pericardial effusion. Then we need to do a chest x-ray, we need to do an ECG, we need to do an echogram. And therefore, that is why, as I said, I usually involve a cardiologist in patients who we are admitting, because most of the time we are admitting because they have symptoms or signs that it's going to go in this direction of a pleural or a pericardial effusion. We need to also do a pregnancy test, and I've started this because right now, mostly we do not, if a patient has signs or looks like they're going to get OHSS, we do not continue to put back the embryos. And therefore, we rarely will need to do a pregnancy test. But there are those patients that surprise us and they get a late onset OHSS, and I've had a couple. And so we might not know that they're pregnant when they present, and therefore it's important for us to do a pregnancy test if we did an embryo transfer post the IVF cycle. We also need to measure electrolytes daily. We need to do a complete blood count daily, but this obviously will be guided by how the patient is doing. And then liver functions and liver enzymes, and serum creatine and creatine clearance should be repeated as necessary as well. So what is the medical management? So how do we manage these patients? Remember, we know that the biggest problem is that they are having third spacing, and therefore we need the key thing for any patient with OHSS is to correct the circulatory volume. And so every effort should be made to do this, because we need to ensure that they have adequate renal function, and we don't get into things that we cannot then reverse. So we will need to replace the volume, and usually we do it by using intravenous crystalloids. We like to use 5% dextrose, in 5% in normal saline is the preferred. And usually we give about 3 liters per day, 2 to 3 liters per day. Also depends if the patient is able to drink. So if they're drinking and their intake is coming up, then we titrate accordingly. And obviously our aim for this is that we need to increase the urine output to at least 20 to 30 mLs per hour and reverse the hemo concentration. Colloid or plasma expanders can be used if we're getting into a compromised state. We have used albumin. I remember my first patient, I went to Avenue and everybody was so scared of using albumin because somebody reported that everybody dies when they're on albumin. And therefore that patient really taught me, because she's a patient who everyone was scared of, plus everybody was scared of using albumin. I don't understand why. And I was very new to this field. So I took their advice. But the minute we actually gave her albumin, she had already gone into pericardial effusion. Everything stopped. I mean, everything, it was so miraculous. Everything went back. So I am now more aggressive, and I don't fear using albumin and the expanders, but I mean, it's not a first line. We must first replace the volumes before we get to the albumin, and also there must be an indication to use the albumin. Electrolyte replacement is also something that we do. So for most of the patients, we fear hyperkalemia. Obviously because of the cardiac dysrhythmias that may occur. So we do, in a lot of patients, we'll give calcium gluconate to protect the cardiac tissue, but obviously guided by the levels that we're doing every day. We do not restrict salt and water. We have seen that it doesn't make a difference in terms of the management. So the major thing for electrolyte replacement is that we usually give calcium gluconate. As I told you, I'm usually with a cardiologist, so most of the time it's a discussion we have, and they're able to guide, and we do it together. Prevention of venous thrombosis. Remember that this is a very, very likely thing, and it is actually the most serious complication of OHSS. I don't know of any. I know of a patient who collapsed and had the venous thrombosis and actually died. So it's really, really important that if we have any patient who has OHSS and is in our care, we need to give prophylactic doses of enoxaparin, and just 40 milligrams per day is enough to prevent this. Remember, these patients are bedridden, they have all this ascites, they already had stimulation, with all the hormones, and therefore they're high risk for venous thrombosis. So it's very important to prevent this. For patients who are pregnant and then get OHSS, the recommendation is to go up to 20 weeks, which is mid-trimester, because we have seen that with these patients, sometimes we get a late thrombotic episode. So this is more in patients with moderate and severe, not the mild patients with OHSS. Do we give antibiotics or not? Routinely, we don't give antibiotics, but if a patient is in hospital, and of course you've done catheterization, we were giving all these punctures, we're draining pleural fluid, we're doing ascitic taps, I mean, then such a patient should be on antibiotics. Remember also the hemogram is a bit false because we already have elevated white blood cells on its own. For patients who are in hospital, we do give antibiotics. Diuretic use, we do not give diuretics. Actually, they've been known to be harmful, except with patients who have pulmonary edema. then we would bend the rules and give. So, and then dopamine therapy for patients who, we only use it in oliguric patients and with very severe OHSS, and it seems to help improve the renal function of these patients. So now it comes to what a lot of people ask. I know everybody asks, are you going to tap the patient? Are you going to tap the patient? So aspiration of the acidic fluid, when do we do it? I know that some doctors do it even in the clinic. The patients come, we remove a little acidic fluid, leave the patient. But to be honest, the indications are few. Usually we prefer to do it in a hospital setting, or I prefer to do it in a hospital setting. I know for some clinics, they do it, especially for the donor cycles, they do it out as an outpatient. But the indications are, if we do have a tense acidic condition where the patient is having severe abdominal pain, it needs to be done. Of course, if there's respiratory compromise shown by tachypnea and pulse oximeter, we really need to then give the patient some relief. And if there's a renal compromise, then we also need to do it. And how do we do it? We can do it in two ways. We can do it abdominally by just putting an abdominal tap. And we can actually tap between 200 to 400 mLs without embarrassment. But this needs to be guided also by the patient's symptoms and by the fluid that we are replacing. It is best under ultrasound guidance, so we just don't do it. We need to sometimes, okay, not for everybody, but it is best because we remember we have enlarged ovaries, so you could actually go into an ovary and actually cause a lot of bleeding. So we do it under ultrasound guidance, and we then also obviously monitor the plasma protein, and albumin should be infused if needed. And I've seen for patients who we are tapping, a lot of times we may give a little bit of albumin per day as we tap. How frequently do we tap? Some patients we tap daily, sometimes we tap every other day, depends on how fast the acidic fluid reaccumulates. For transvaginal aspirations, we also do them. They are done under ultrasound guidance. It's just the same way how we remove the oocytes. So same kind of thing, requires no anesthesia, quite easy. Patient doesn't feel much pain. And this is usually what we do in the clinic if we are doing a tapping. We rarely do an abdominal in the clinic. We'd probably do a transvaginal aspiration. Now, autotransfusion of acidic fluid is not recommended, so I won't really discuss it. But I just thought to mention it because it's not recommended. So what do we do with patients who have pulmonary complications and maybe have a pleural effusion? Do we tap? Do we not tap? I think the first thing is really that we need to assess these patients very well. We need to do a complete physical exam. We need to do a chest x-ray and see how much fluid is there. We usually will get, with most patients who have OHSS, some hemothorax in the right, and that's just because of the way it is. But should we tap that? Usually we don't, and it actually resolves quite fast as the patient goes getting better. But if it is severe and we have it in both chest fields, then we think, okay, we might need to do it. I think we've done it on one patient who had respiratory compromise, and that's the only patient we've done it in. And patients who have also pericardial effusion, rarely do we do any tap for that, so that doesn't happen. But for patients with the bilateral pulmonary effusions, we can consider it. Surgery. Now, when do we do surgery? I mentioned that I'll discuss this later, but surgery is usually performed very rarely. I don't think I've never done any required to do any surgery, but there are indications that would make us do surgery. And one of them is if you have ruptured ovarian cysts. Remember that these patients have enlarged ovaries. They have, because we've already aspirated the follicles and the oocytes, then we have blood inside the follicles, and they may rupture and be causing lots of pain, and we may have to go in and stop that. Rare, very, very rare. Ovarian torsion is another reason we may have to go in. And this is a very confusing diagnosis because now the patient has very enlarged ovaries. A scan rarely will pick up ovarian torsion. She's in pain. We don't know if she's in pain because of the tension of the ascites or because of the increased inflammatory response because of the enlarged ovaries. But I do think if we suspect that there is torsion or the scan shows us any decrease in Doppler flows, then we go in and correct the torsion. A lot of times it's too late, and sometimes the ovary does have to come out. But again, I've never had to go in for ovarian torsion, thankfully. Now, patients with ectopic or a heterotrophic pregnancy, this is a nightmare because, again, how do you know it's ectopic? The patient, especially if she has a heterotrophic pregnancy, her beta HCG levels are going up and she has a pregnancy inside, but then she has pain. If you look at a scan, we have fluid in the abdominal cavity anyway because of the ascites or because of some blood from the cyst. So it's a very difficult diagnosis, but if we suspect ectopic pregnancy, and if you're able to see it, remember also the ovaries are very enlarged. So doing a scan it's very difficult to see a very tiny ectopic pregnancy in the tubes. But if you do suspect ectopic pregnancy, especially ectopic with a heterotrophic pregnancy, then you must go in and correct. Otherwise, the patient will bleed to death, obviously. And then pregnancy termination. This is a very, very rare, but there are patients who have gone on and gotten pregnant because an embryo transfer was done, and they are in HDU, moving on to ICU. They're in critical condition, and the only way we can stop the progression of the disease, because remember we said OHSS is really caused by beta HCG levels, is to terminate the pregnancy. So in these cases, some of them would have to have a pregnancy termination. Again, I said quite rare. I don't know of any that has had. I've read in literature, but I've never seen. Yes, so those are the surgical managements. Now we had discussed the prevention, or I had talked about how to prevent OHSS, and I had said that luckily, I think it's a rookie. A lot of the times, I won't say not that it. I don't want to be proud, but I think it is more a disease, or OHSS is caused when we are a bit younger and don't understand what we were doing. So it is now possible to have an OHSS-free fertility clinic. As I said, I haven't hospitalized, or we haven't had to go in with somebody for a very long time. There are a few patients, but usually if those patients will be mild because we will have done all the preventive measures. So how can we prevent OHSS? There's something called primary prevention, which means that we prevent it way even before we start stimulating the patient for an IVF cycle. And one of the ways is for patients to have an individualized controlled ovarian stimulation, meaning we assess the patient on the basis of risk and therefore decide on the treatment protocol for that patient, because we do know that there are protocols that patients are prone to OHSS, and there are protocols for IVF that the patient is unlikely to get OHSS. So that's one of the ways to do it. So individualized treatment. Another way is to give patients metformin. Remember, we said that PCOS patients are the ones who are more likely to get OHSS. So we think, or research has shown that if we give metformin, usually 1,000 to 2,000 milligrams per day, at least 2 weeks prior to the IVF cycle, they will have a reduction in OHSS, but rarely do we have time to 2 months. Usually patients come and you start IVF, so not really done. Laparoscopic ovarian drilling prior to stimulation can also be done. This is rarely done, I will tell you, because we have found that unless we do it very right, we're having real problems with drilling, but it was thought that this was a way to prevent it when we did not know about the next way, which is an antagonist cycle. So an antagonist cycle is a cycle where we will not, it's easily controllable, and we do not have to use a HCG trigger, and therefore we rarely will then get into the syndrome of OHSS. And secondary, how do we prevent it? So secondary means we're there, our patient looks like they have a lot of follicles, and a lot of follicles means more than 11, or I mean, more than 14 follicles that are of the size greater than 11 on about day 6. And we are not going to be able to prevent it any other way than by doing a few things like coasting. So coasting is, we don't give gonadotrophins, we wait and we wane so that, yes, the oocytes are growing, but we're giving them less boost and therefore less granulosa cells, and therefore less likely to go into OHSS. The downside of that is that we could lose the cycle. The eggs could shrink because we're not giving them the stimulation. So rarely done, rarely done now. The other way we could do it is that we cryopreserve all embryos. Remember, pregnancy is a factor that will cause patients to go into OHSS because of the beta HCG levels. So if we take out the oocytes, do everything that is required, the fertilization, the ICSI, but then do not put back or do not do an embryo transfer on the patient, then the likelihood of OHSS goes down. We could cancel the cycle. This was done earlier on when we did not have the antagonist cycle. So the antagonist cycle is one that is preventative for OHSS. And this, I think antagonist cycle came up maybe about 15 years ago. So before that, they would cancel all cycles that looked like they were going into OHSS. But today we do not cancel cycles. We could give some intravenous albumin, and that may help. We do give carbagolin. So I give carbagolin about 0.5 milligrams from the day we give the trigger until for about 5 to 10 days. And it usually actually assists. Low dose aspirin has been shown to help. In vitro maturation of immature oocytes. So this is what can be done, but this is super hard, and it only is done in very, very good labs where they have all the facilities to do this. And what this means is that instead of removing oocytes when they're mature, we remove them maybe on day 6 or day 8 of a cycle. Usually a cycle goes until day 10 or 12 or 14. So in a very immature phase, we retrieve the oocytes, and therefore the patient will be okay. They're out of her body, but the oocytes then need to be matured. But this really is very difficult to do, but it's done in Europe in some of the best centers. And then vasopressin-induced VEGF secretion blockade can also be used. I haven't seen this medication, but they say it does help. Yes, it does help. So I think prevention obviously is better, but sometimes we are not able to prevent. So even with the best patients, sometimes they will go into OHSS, especially difficult patients, unfortunately. I've had difficult patients who do not want to drink, do not want to cooperate, and those are the patients who are more likely to go into OHSS and need admission. I think I have done my 50 minutes and I am therefore done. These are my references. And I thank all of you for your attention and even for giving me the forum to speak. And I'll be welcome to any questions. Hello?
Hey, thank you so much, Dr. It's disturbing me. Thank you for the informed presentation. We really appreciate. We've gotten so much information already. I just hope now we've gotten the way forward so that we don't miss diagnosis with something else. Thank you so much. Before we go into question, to welcome our chairman, Dr. Okello, who has some interesting information about the conference that is upcoming. I know we're all excited about it. Karibu, please welcome Dr. Okello.
Thank you very much, Dr. Mohammed. Thank you very much for this opportunity. Sorry, I am going just a short announcement before the sponsors for the session come on board as they are getting set. It's got to do with our conference. But before I get there, it's just to let you know that for those who are joining us from out of the country, the August is here. Shelmet, could you mute this is some, thank you. August is here, and there are two main events that occur in August in Kenya. One of them, which we should all try to get to be involved in someday, is the migration of the wildebeests. And the second main event is the conference or the Congress of the Kenya Society of Anesthesiologists, which we usually hold together with the Critical Care Society of Kenya. We are going to have this conference starting on 18th to the 20th of August this year. And this is just a call for those who haven't registered yet. Many of you here have already registered and are already enjoying the conference. Actually, the moment you register and you download the app for the conference, you're already in the conference and you can start interacting with the fellow delegates, with the industry partners, the sponsors, and everyone. So do not be left behind. To register is pretty easy. You go to the website of the Kenya Society of Anesthesiologists. That is anesthesiakenya.co.ke, or you can directly go to the microsite at conference.anesthesiakenya.co.ke. And for those who are finding this rather unwelcome, we have an option. You can easily send your registration fee through our pay bill number, that is 872224, 872224, and get in touch with Shelmeet, and we'll guide you through the rest of the process. It is that easy. So welcome all of you, those members of KSA, the non-members, and even for the fertility experts, you are all welcome for this one-of-a-kind conference starting on the 18th to 20th of August, that is next month, this year. Do not be left behind. There's a rich scientific program. We have plenary sessions, we have workshops, we have problem-based learning discussions. You have the opportunity to network with colleagues from across the globe. You have the opportunity to meet our very esteemed industry partners, and the options, the possibilities are just limitless. So welcome all of you, and kindly join in this, and let us celebrate this together. Thank you very much, Dr. Mohammed, and I hand back over to you to continue with the rest of the program. Dr. Shueha, are you still with us?
Sorry, I'm on mute. I was on mute. Sorry. Yes, I'm still here. To go to question and answers, there are a few questions that have been posted with all the good presentation from Dr. Wanjiru Ndegwa. So the question that has been posted first was why dextrose 5% normal saline, and what about large volumes of normal salines that can trigger hyperchloremic acidosis, Dr. Would you please answer?
Hello?
Hello? Did you get the question, Dr.?
Yes, the why 5% normal, why 5% dextrose with normal saline? That's the question?
Dextrose.
I think we use the dextrose because of because of the patients are not eating as well. But to be honest, I'm not an anesthetist. I just know that this is the fluid that is recommended and not ringers. So maybe an anesthetist could, one of you guys could actually help answer that. Hello?
Yes. Hello? Okay. We will get back to the question and answering noise, and we'll allow the Novartis to present. I think it's just a function that is neighboring to my. I'm trying to look less of that background noise, but for the time being, please let's allow the sponsor company to present for us their presentation for today, when they are going to talk about post-operative nausea and vomiting.
So thank you very much. So I'm trying to share my screen. I hope you can see me sharing my screen.
Yes, we can see it, Lucy. Go on.
Okay, I'll start. Okay, before I start my presentation, I did not come alone. I'm with my colleagues. They're on the line. Maybe they can introduce themselves. Paul, if you're on the line, kindly. Hello, Paul or Sophie, anyone on the line from Novartis?
Hope you can hear me. My name is Paul Sakwa. You can hear me?
Yes, we can hear you, Paul.
Yes, thank you very much. My name is Paul Sakwa. I work with Lucy, and I'm very glad and happy to be part of the team, joining the team to partner with the KSA for this function. Thank you very much.
Thank you, Paul. Anyone else from Novartis? Okay, maybe I can start. Before I start on my presentation, I hope you can all see my screen, Zofran. Maybe I can say a brief history of Zofran. Zofran was first discovered in the 80s in England by an affiliate company known as GlaxoSmithKline. And from 1980 to 2006, 2006 it is when it gave its patent to other companies to produce generic. And in 2016 is when Novartis acquired Zofran. So welcome. So Zofran in prevention and treatment of nausea and vomiting. So Zofran is ondansetron hydrochloride. So what are the incidents of postoperative nausea and vomiting? So nausea and vomiting may affect up to 80% of patients who undergo outpatient surgery. So more than 30% of patients may experience PONV after leaving the surgical center. In some patients, this can last up to 5 days after surgery. So PONV is among the most common causes of unplanned hospitalization, admission after outpatient surgery. So what are the causative factors of PONV? One, patient characteristics. Female are more prone to PONV than men. This is because of the hormones that are in female. Anesthetics agents, NO2, inhalation gases, opioid analgesic, pain, stimulation of the pharynx during intubation and induction, type and duration of surgical procedure, direct disturbance of the gut during abdominal surgery, disturbance of vestibular apparatus during long distance wheeling on trolley or ENT surgery, psychological factors. Maybe so many people fear when they hear they are going to surgery. I mean, everyone fears, and also anxiety, hypoxia and hypotension during or after operation, early mobilization. So patient at higher risk of PONV. Patient with a history of motion sickness thought to have a lower vomiting threshold. PONV is more severe and prevalent in women more than men. Non-smokers are more likely to experience PONV. Young to middle-aged, children, twice the adult incidences. That means children experience more PONV than adults. Obese patients who have large, why does obese patient? This is because they have large adipose deposit, which means they store anesthetic drugs more in the body. So what is the mode of action of Zofran? So Zofran is highly selective, competitive, 5-HT3 receptor antagonist. Zofran does not interact with other 5-HT receptors or receptors from other transmitters. So Zofran has also dual possible modes of activity. So maybe we can look at the dual possible pathways of activity. One, antagonizing peripheral 5-HT3 receptor and interrupting emetogenic stimuli acting directly on GIT, this preventing them from entering the vagus nerve. Number two, antagonizing the central 5-HT3 receptor and thereby blocking the reception of emetogenic stimuli by the CTZ zone. So what are the formulations of Zofran? Zofran is available both in injectable and also oral. Injectable, we have the 4 milligrams per 2 ml and also the 8 milligrams per 4 ml. And the oral formulation, we have the 4 milligrams tablets. We also have the Zofran Zydis, the 4 milligram, the one that you put sublingually, whereby some patients usually vomit excess that they cannot retain anything in their body. So Zofran Zydis is recommended for such patients. So Zofran pharmacokinetics. Zofran has a very predictable pharmacokinetics. It has a peak plasma level within 7 to 11 minutes of administration of single IV 4 milligrams dose. It also has a rapid absorption with a maximum peak plasma concentration, that is 30 nanogram, being achieved in approximately 1.5 hours after 8 milligram oral dose. It has a half-life of 3.4 to 4 hours and no accumulation in the body, which means it is safe. So Zofran in adult dose in PONV, one in prevention, that is during surgery, you give 4 milligrams IV at induction of anesthesia. And when you're using Zofran on treatment, use 4 milligram IV as a single dose. So in pediatric, you dose according to the weight of the child. Less than 40 kilograms is 0.1 milligrams per kg single dose. More than 40 kilograms, dosage is 4 milligrams IV single dose. Then Zofran dose is given prior to, at, or after induction of anesthesia, or after surgery. So let's look at Zofran clearance. Zofran has an extensive metabolite, is extensively metabolized, which means less than 5% of dose reaches urine unchanged, which means it is safe renally. So the renal clearance of Zofran is low, which means less than 5% of the parent drug is recovered unchanged in the urine. And the major route of systemic clearance is the hepatic metabolism. So in renal impairment patient, no alteration of dose or frequency of dosing or route of administrations are required. So in elderly, in CNV, especially in CNV for patients who are 65 years and above, Zofran has been found that it is well tolerated with no change in dose, route, or frequency of administration. And in severe hepatic impairment patient, clearance significantly reduced and serum half-life significantly prolonged in subjects with moderate or severe impairment of hepatic function. And the total dose should not exceed 8 milligrams. So Zofran is well tolerated, which means it has no effect on the cardiovascular system, no effect on the respiratory system, and it has no sedation. So Zofran safety profile. Zofran side effects are generally mild and transient, which means if there is headache, it might be sensation of warmth, flashing of head or epigastrium, constipation due to increased large bowel transit time. There might be fever and malaise or fatigue. Rarely visual disturbance if IV administration is too rapid. So Zofran should not be used in pregnancy, especially in the first trimester, and also should not be used in lactating mothers. This is because drug is present in breast milk. So mothers receiving Zofran should not breastfeed their babies. So Zofran should be protected from light. Dilutions are stable for 24 hours at normal temperature, and lighting and hence infusion do not need protection. So dilution should be done with compatible intravenous infusion, that is sodium chloride or sodium chloride or plus potassium chloride, glucose IV infusion or glucose IV infusion plus potassium chloride, mannitol, ringers. So Zofran should not be administered in the same syringe of infusion as any other medication. So in summary, Zofran is superior to placebo in prevention and treatment of postoperative nausea and vomiting. Zofran has an established safety profile. Zofran is also recommended in both adults and children above 6 months of age. Zofran is well tolerated. Zofran is available in a number of formulations, that is IV, injectables, and tablets. Hence, Zofran enhances patients' quality of life. Doctors, your answer to post-operative nausea and vomiting is Zofran. Thank you very much.
Thank you very much, Lucy, for your presentation and your talk on on Zofran. If you have any further questions to the participants, you can put them on the chat box as we will get through them. There's a question that had been left hanging. That is, why do we use dextrose in saline? And Dr. Ndegwa threw it back to us. I am sure within our ranks here, there are people who have managed these patients. And is there anyone willing to take on this question? Those of us who work closely with the fertility experts, not necessarily to cause, but to manage OHSS. I'll be hoping that someone will come up. Maybe you can just raise your hand and get unmuted to answer the question. In the meantime, Dr. Ndegwa, there are a lot of accolades for your presentation, and thank you for that. There's a question here from Dr. Imbaya. He's asking the kind of consent that you obtain before you start this process. Maybe you can, in summary, just tell us what you tell these patients and the kind of consent that you get.
Thank you for that question. So just to go back to the dextrose one, I mean, I did say that probably it is because we are correcting dehydration, but there's also an element that they're not eating, they're nauseated, so the 5% plus maintenance. So I don't know if that's what the anesthetist will also say, but that's the reason we use it. Now for the consent of a patient, yeah, we do tell the patients that this could be the complications that you, and I mean, you know, the risk factors, the patients who are prone to PCOS, I mean, who have PCOS and will have a higher likely output as incidence of OHSS, we know. So we do tell them. So they are aware. The consent actually also, you have to sign before an IVF cycle that you have understood what IVF is and you have understood the complications. Therefore, they are well informed. But obviously, you know, when it happens, it always comes back to you. So, yeah.
Doc, do you specifically mention to them OHSS?
Yes, we do.
All right.
Yep.
And there's another question here about monitoring. Do you have a specific regimen or regime that you use to monitor when you're doing your ascitic taps? Is there any way you monitor, or you just tap the fluid?
No, I think there's no regimen per se for tapping, because firstly, tapping is very rare. We don't tap always. As we said, if the patient is drinking and has no compromise, respiratory compromise, the albumin levels are okay, everything else seems okay, we do not tap. But once they get into the hospital and we are therefore, we have to tap, we are monitoring all their parameters. And therefore, what is important is therefore, they either have to tense ascites or they have respiratory symptoms. So therefore, we decide on how much to tap per day. We may tap every day, we may tap every other day, and we tap mostly anything that gives them relief. We don't usually tap dry, but we do up to 4 liters we can tap. The problem obviously with tapping is that it reaccumulates. So we also, as we're doing this, we are monitoring the albumin levels so that we don't deplete them. So we'll have done albumin levels before, and probably the next day we'll do an albumin level and we'll top up the albumin if it's less than 35 or usually less than 30. We also then will rehydrate the patient with IV fluids, depending on how much we've tapped. And basically, it's really patient to patient dependent. There's no strict regimen for the tapping. But for me, or for the team that I work with, we only tap when there's a real need, because we do find you just keep tapping every other day or every day. Yeah.
Thank you. Thank you very much. I think that is very informative. And on the same vein, in terms of tapping of ascitic fluids, sometimes we experience quite a bit of fluid shifts. Do you have a specific way that you manage these fluids in terms of IV access, the kind of cannula you put central lines?
Yes, we could put a central line, especially if the patient has a lot of edema. Then, you know, the lines are very difficult to get. So we have had to put central lines for a few patients. But otherwise, we just put a wide bore needle, and that usually is sufficient. But yes, there are patients that we do have to put central lines.
Okay, thank you very much for tackling these questions. I don't see any further questions within the chat. And I also don't see any hand up. So Doc, just to come back to you, maybe what would be your take-home message for this audience in terms of OHSS? One message that you'd like us to leave with from this.
Well, first, I'm grateful. I don't think I've talked in front of anesthetists, so I must say I'm very thankful. I've seen a lot of anesthetists that I work with, and I'm grateful that they're listening in because they know what kind of work we do. And I think you guys are funny people, so I really like working with you, just so that I can mention it. A lot of you put music in the theater and make us really laugh. Gynecologists are a little bit boring, but anyway. So the last comment as we go, as you leave for OHSS, is that one, it's really preventable, but there are the cases that we will not be able to prevent. And those patients will need admission, and they will need the care of an anesthetist, a cardiologist, and the gynecologist to work as a team. And I think the things that are life-threatening are obviously the venous thrombosis, as we said. And if it got into cardiac, pleurocardial effusions and the likes, that's when we really will get into trouble, and renal failure. But I think it is a manageable disease once we know what we're tackling. I don't think there are any rules that are really set in stone. It's really patient-based, and what the investigations that we do tell us every day. But it is a manageable syndrome.
Thank you very much for that, and thank you for your kind words. What I get from what you're saying is that it's important for us to work as a team. It's important that anesthesiologists understand what you're doing and the potential risks, and vice versa. You also understand us, in addition to the good music that we bring to your theaters. We will welcome you for more talks, not just you, but within your society. If there is an area that we share, we'll be more than willing to host you. And maybe once in a while, we could also come to your meetings. I hope they are interesting as well. Thank you very much, Doc. And with that, I think we've come to the end of today's webinar. May I extend gratitude to our sponsors for the day, that is Novartis, for enabling us to have this session. Dr. Ndegwa, for taking your time an hour earlier than usual and sharing with us your knowledge, and to all the participants for coming here. It would not be possible for each, if not for each and every one of us. And as we leave here, remember to go ahead and register for the conference that is coming up on the 18th to 20th of August. You can get further details on our website. Goodbye, everybody, and have yourself a good night.